So, ladies and gentlemen, I was asked to speak a little bit about timing of pelvic physiotherapy for the prevention and treatment of postnatal pelvic floor dysfunction. And first of all, Alex, I would like to thank you, and also that you did it in so eloquent English, I must say. So when we look to our own country in the Netherlands, then we see that there is about an incidence of deliveries, vaginal deliveries, of 200,000 a year on a population of 17 million people. And that 1 out of every 3 peripartum women have pelvic floor dysfunctions. That has to do also in our developed country, if I may say so, with insufficient preparation. The problems that occur later on are psychologically devastating for people. And actually, what we say, is physical therapy really so important? Because when we ask this to physical therapists, they will all say, yeah, sure, it's very important, because vaginal delivery and pregnancy are the most striking problems related to pelvic floor dysfunctions. When you ask a gynecologist, and when he's sitting at the table, he will say, yes, it's very important. When you ask the obstetrician, he will say, and what about the long-term results? Is that really mattering? We know all that the first baby is making the biggest damage. We know from studies from The Lancet that about 80% of normal vaginal deliveries go along with problems of the pelvic floor. Not all of them need to be treated, for sure. So it is a matter also who needs the treatment. When we look to the reviewing, then we see from Brunström in 2008 that he says, this peripartum intervention is not that important. That's not important at all. Actually, at the same time, about tremendous potential for improving pelvic muscle exercises, education, and targeting at-risk women in peripartum period. And again, here the word risk. Is that the vaginal delivery at itself, or is it some women with a vaginal delivery will develop this kind of problem? And can we find out who are these women? Actually, the same group of Brunström in 2013 have changed their attitude towards this problem and say, no, it is an important strategy, actually. When we look at the consequences of pregnancy, actually, there are many, many, many. I just brought a few of them, like, for instance, the cardinal uteral sacral ligaments. All these ligaments can be stretched, and they are very important, these ligaments, for the maintenance and the support. And so there can be an anterior displacement of the uterus during straining or under influence of gravity. We see that there are problems that lead to stress urinary incontinence because of nerve supply, the pudendal nerve that can be crushed or tracked. And then the vagina itself can turn away from its interpelvic attachments with subsequent loss of superior vaginal sulcus. We see a lot of different things that can lead to an increase of levator hiatus. So many of these things related to the pelvic floor have been studied extensively. We know that there are the obstetric trauma, where we see that there can be a problem with the internal or with the external sphincter, and that there can be damages. And what we see in literature is that they say when there is more than, let's say, 25% of the complete circle damaged, then no physical therapy because we need to repair. And so many of those patients have occult problems. They don't know even that they have that problem. And now, with the new technology, we know more about this. And because of this, there can also be development of strategies related to this. So, physical therapy for these people, would that be the Holy Grail? Yes or no? Let me look to what the group of SIF did. And we see that with physical therapy on a 1-year follow-up study, it demonstrates that there are effects. And what she said already, it needs to be an intensive program, and then it can be effective in the prevention and treatment of stress urinary incontinence. And then the benefits from this pelvic floor muscle training are still present after 1 year. But again, my obstetrician said to me, yes, after 1 year, but what about after many more years? So the women that have the first child, many of them will get another child within the next 2 years after this. And it means that it is very difficult to develop studies with long-term results. If you want to have, for instance, long-term results after a primipara, 5 years, 6 years, 8 years, So then this is something you cannot ask of people. Can you really wait with your child that we have a follow-up of 8 years again? When we look to the antepartum pelvic floor muscle exercises, then you see that here biofeedback is there, so another adjunct to the pelvic floor muscle training. You see that there are different training, let's say, levels of healthcare professionals, and we see that they do not result in significant short-term, so at 3 months, decrease in postpartum urinary incontinence or pelvic floor muscle strength. So postpartum pelvic floor muscle exercises, when performed with a vaginal device, and again, here, something added to it, so a device that gives resistance, not only pelvic floor muscle training, then we see that they appear to decrease postpartum urinary incontinence and increase strength. You can perform Kegel, so-called Kegel exercises, and actually they are ineffective in preventing postpartum urinary incontinence, is the opinion in 2003. And so what we can see that postpartum pelvic floor muscle exercises do not consistently reduce the incidence of anal incontinence, so another kind of pelvic floor dysfunction. When we look to somewhat later evidence, we see that 22 trials in primipara pelvic floor muscle training can really prevent urinary incontinence up to 6 months after delivery. But again, to convince our obstetrician, we need the long-term effects. We see in a study of 2013, 14 SCTs, pelvic muscle training can prevent urinary and fecal incontinence. And what we see, if we know more about what are the pros and cons of pelvic muscle training, then this changes the attitude of those people that are going to refer the patients or the patients themselves. And what we see in a study that of Heinz Goebel, pelvic muscle training advantages seem to decrease with increasing duration and follow-up, and is lacking after 12 years. And once again, I spoke about the primipara, how difficult this is to do, and we have to discuss this, how this was possible. So what to do? Is there something that we can do? Yes, I think we need to convince the obstetricians. I think we need to convince the women that have delivered and have a problem, that pelvic physiotherapy really can matter. So the long-term effects is important. And so we applied for in the Netherlands for a grant from our government, and we received it recently, and we are developing now a study where the mother will be central, and we are going to try to make a multidisciplinary approach to discuss these kind of things. You see our beautiful tulip, but actually it is really to support the interest of all the medical specialties and paramedical specialties in the women that have delivered, because it's very important. So when you want to have something going on, then you have to do a diagnostic analysis of the usual care. What are the barriers and facilitators? Because when I ask the obstetricians, do you believe in physical therapy? Should we do it? They all say yes, but nobody does it. The gynecologist, same thing. Physical therapist, do we really have the program that matters as a comparison with those programs that not matter that much? So what we see here, that we should develop a small-scale quality improvement pilot project, and then a bigger randomized clinical trial, first nationally and then internationally, and then we get some ideas about the long-term results. So we made a website about MotherFit, where it is in Dutch, but it can also be available in other languages, where we give information about what is happening during the pregnancy and during the delivery, exactly those kind of things that women would like to hear and to see, and to prepare them for their delivery, and also what they can expect from their pelvic physiotherapy. What is important is that we make a differentiation between those people that need it and doesn't need it. So we came up with a simple idea. When the risk factors, prognostic factors, that the doctor can assess during the regular checkups during the pregnancy, and also after the delivery, the first time that the patient comes back, or the woman or the mother comes back to the doctor, then we can do this assessment of the pelvic floor. So what mostly happens after delivery is that the woman goes back for the last time to the doctor or to the midwife, and the doctor says, and Baby sleeping well? Yes, 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 yes. And breastfeeding, okay? Yes. No information about the pelvic floor. While they can assess easily the pelvic floor just once to see whether there are this kind of problems. So, assessment of the pelvic floor together with these risk factors that are all well known, big head of the baby, the weight of the baby, the prolonged second stage, etc. When that is there, then you can say this is a plus. And if the woman says, I have no problem at all, okay, then you can say this is a mid-risk. And if both, so the woman says I have problems, and the doctor, then it's high risk. And the others, when there is no problem at all, and also the doctor says there is no problem, you can say it's a low risk. So you can differentiate cost-effectively those people that should have this kind of training program. And what we can do is information, instruction, and then also giving the assessment by the gynecologist with all this kind of different possibilities that they have to identify these risk groups. And then the assessment for those that are in the mid and in the high risk group, they can go to the pelvic physiotherapist, do their assessment on the functionality of the pelvic floor and other things that are related to this, and look also to the borderness of the problem within these women. And because of the assessment, we will have our parameters for the training program that we can do. And the program that we are going to do, you have seen this picture, that is from Sif, because we use her program, because it's evidence-based program, to be the basis of our program, where we are going to give women, and we can discuss this later, those things that women need, women like, during this pregnancy and after the delivery as a program. And we know, Sif have already assessed it, that it needs to be intensive, that it needs to be motivational, so that they will adhere to this program, and it should have a head and a tail, and so that we can see what are the benefits of this kind of program. And I would love to answer your questions. Just one thing more. When we look at the different studies in the Cochrane, there are studies, many studies summarized. Some of those studies are very large studies, but with a very low intensity of the training program. They are mixed up with those programs that have a high intensity, but maybe smaller numbers. And it means when you are going to do a meta-analysis, that those studies that have really the elements that matter for those people, that they will fall out of the real picture because of those other studies that are larger but are less important. Thank you very much for your attention. I look forward to your questions.